investigation so far. 40 years from Turkey, intermenstrual bleeding, no investigation any so far. What do you think? Before see the option.
Before seeing the option, she is coming from Turkey. Turkey is a country where
Infection.
no, not infection. Country is Turkey is like our countries. We don't have a pap smear as a national screening program. Our countries don't have a national screening program. So she is coming. She is a new arrival. She is 40 years old. So she is in the age for screening.
In the age of what?
National Geographic.
Look, Dr. Iman, she is 40 years old. 40 years old. She still have she is up to, we screen up to 65. So she is still in the age to be screened by pap smear. So I think the most appropriate thing here is to admit her, or to invite her for the screening. Previously, we were screening by, first we were doing the pap smears, and after pap smear came the liquid cell cytology, liquid based cytology, and now we are screening by what is the screening now?
Human papilloma virus اللي هو screening ده اللي هو أكيد.
Yes. Now the screening is human papilloma virus triaging. We are doing the triage by human papilloma virus. So this question is according to the old guidelines. So even with the new guidelines, she is supposed to come for cervical screening, whatever the method. Okay.
The first time I think about it, I think it is complete blood count, CBC. Why not do?
Why CBC?
Let's see the option. Let's see the option,
wait,
please.
But wait, why CBC? What you are thinking?
Maybe and by.
Yeah, but this is not. She will not come for us. She will go for
GB.
Yeah, she is going for GB or internal medicine. She will not come to a gynecologist.
Okay. See the option. See the option. Good. This distracts us. Cervical bunch, chlamydia, colposcopy, guided biopsy, complete blood count, dilatation cartilage, endocervical cartilage, endometrial biopsy, pill, hysteroscopy biopsy, pap smear, reassure, transvaginal ultrasound of the pelvis, ultrasound of the abdomen. So I will choose pap smear. Let's see that.
But I'll tell you. For me, it changes in your book from pap smear to cervical screening. No, cervical screening, because pap smear now is not our first line. So just change it from pap smear to cervical screening.
Okay.
Let's see.
What he changed pap smear and cervical inspection is the first stage in the investigation of abnormal bleeding. Many countries outside the UK don't have a routine cervical screening program. Okay, but we will cervical screening. Yes.
Yeah, go for cervical screening first.
Okay. Number 4, 54-year-old woman present with spotting of blood vaginally on wiping over the last few weeks on and off. She went through menopause 3 years ago and she is otherwise well. She is more active since her recent knee replacement surgery. Her pap smear 2 years ago was normal, as were her other smears. Keyword بقى spotting. Say the keyword, doctor.
She is postmenopausal. She is a postmenopausal woman. coming for postmenopausal bleeding without any, and her pap smear is normal. Sorry, her screening is normal. So what do you think? What is the first line investigation for someone coming with postmenopausal bleeding?
postmenopausal pill and endometrial biopsy by hysteroscope مثلا أو hysteroscopic and endometrial
What
biopsy
is the cut line? How will you know the cut line? Well, how you
by
know the cut of length?
transvaginal ultrasound. Yes.
So
Sorry.
what is first?
Yes. So yes. postmenopausal bleeding transvaginal عشان الاتروفيك endometrial to exclude الاتروفيك كده يعني.
No, not just in atrophic. First, look. First, you have to do a local examination because maybe she have atrophic vaginitis, but most probably it is something in the uterus. You want to check the uterus, so we will not go directly to hysteroscope. No, we will first do ultrasound.
I know بجد. I know بس أنا
This is our.
فرحتش
This is no.
But Dr. Amira,
We know
I
the
want to ask
answer.
for the baby smear for 2 years. Why he mentioned it? يعني can be without
Because
it.
no. Look, she is 45, 54. Sorry, 54 must first he. You would think that maybe she have cervical cancer.
Cancer. So
Yeah,
yes.
but she is up to date with her screening, because if she is not up to date with her screening, the first thing to do is to do a screening.
Yes, if he if the same scenario without this part, we will go to baby smear.
Yeah, if the same scenario. No, look, but also you will do the both at the same time. You will go, because this one for me, if she came to my clinic, I will do both. I will do the screening plus ultrasound, because I'm not sure which is which from the bleeding is coming. It is either because her age have two major risks: the endometrial hyperplasia and cancer is a risk, and the cervical is a risk. So he is first excluding the cervical cancer for you. He's excluding it. So he is directing you to go for endometrial hyperplasia or endometrial pathology. This is how exam questions come. They will direct you to one direction. He will exclude one of the two options you have. He will never give you a scenario where two diagnoses can be right. Yeah, he can give you two diagnoses can be right, but he will not give you, like, he wants an investigation to confirm one diagnosis, not both. Okay.
Okay, and it can also by age, because endometrial maybe most at the old age instead of cervical maybe at mid age.
No. Both are most common in this age group. Sorry.
Okay.
let's see. هو معلش احنا تهنا في السؤال، واحنا فين؟
No,
ايه
it's
الإجابة؟
here. Endometrial baby. Look
Vaginal
here.
ultrasound of the pelvis is the answer.
Yeah, let's go for the answer.
Oh.
Yeah, transvaginal ultrasound to exclude endometrial pathology, obesity, and association with immobility are not uncommon. Okay, what is he telling here? You can find in the big rectangle down in the down in the left corner of the flow chart.
ايه left rectangle on the flow chart اللي هو أقل من
No.
less than 4 milli or more than 4 milli.
No, not this.
اللي هو الأوبستي ده بتاع الأوبستي.
Yeah. Let's see. Let's hyperplasia. Okay. No, not hyperemesis. What hyperemesis? Hyperplasia. Yeah, endometrial hyperplasia. Okay. I will not we will not be doing this, but I just want to tell you where to find this information, just like this, like really quick. Here, this part, the notes. These notes, this summarize the whole guideline. Just read it in your own time, because if we try to read it, it will take the rest of this. It is very important. It contains almost everything in the guideline in these few points. Okay, and this flow chart is the look is a red flag. Just summarize it, memorize it by heart. If you are Egyptian, حفظ حميري على رأي المطري. Okay. This is the only option for this, because you will get it. You will get it. You will get it. You will get a question from this.
أصلاً very difficult أصلاً very difficult.
Yeah. So just write next to it, very very important, and you have to memorize it. And no, it, by the way, it's not difficult. It's very easy. You have either endometrial hyperplasia with or atypical hyperplasia. Okay, endometrial hyperplasia, this is without atypia. First line treatment is IUS. Second line is oral progesterone. Okay, atypical hyperplasia, you will ask yourself one question. Does this patient needs to retain fertility or no? She don't want to retain her fertility, go for hysterectomy, plus or minus bilateral salpingo-oophorectomy. This is according to the patient's preference and age. The second part is if she wants to retain her fertility. If she wants to retain her fertility, we will go for IUS and IUS or oral progesterone. After this, if she is on progesterone treatment, if she is endometrial hyperplasia only, you will review her with endometrial biopsy every 6 months. If she is atypical hyperplasia, you will do it every 3 months. Okay, you will get one of 3 results. Either it will regress, so you will leave the IUS for 5 years, or oral progesterone for 6 months, or you will do total hysterectomy if she still have abnormal uterine bleeding. If it is persistent, what was the reason for taking it? If the reason was endometrial hyperplasia, we will advise, if she is not taking medication, we will she is not on sometimes patient will not she will just tell you, no, I don't want anything, I have just endometrial hyperplasia, I'll wait and see. She refused to take medication. If she was like this, she didn't take medication, you will give her medication. Or if she is already on medication and this is still persistent, you go for hysterectomy and by plus or minus salpingo-oophorectomy after 12 months of medical treatment. Abnormal hyperplasia or atypical hyperplasia, just go for hysterectomy. You tell her, sorry, I cannot preserve your fertility anymore. I'm sorry, this is out of our hands. Okay. So we will for progression, if it progressed for atypical endometrial it progressed. So it was either endometrial hyperplasia without atypia that progressed to atypical hyperplasia, or atypical hyperplasia that progressed to endometrial carcinoma. If atypical hyperplasia, so we will do total hysterectomy plus or minus bilateral salpingo-oophorectomy. If it progressed to endometrial carcinoma, you will treat her as endometrial carcinoma. You will staging and do the whole 9 yards for this. Okay. Follow up. If no endometrial carcinoma, you will follow up 6 weeks for review, and after 6 weeks, then nothing more. If there is endometrial carcinoma, you will deal here. Any patient with endometrial carcinoma, it's out of our hands now. Now she will be treated as an endometrial carcinoma patient. It's not in this. You will treat her as per FIGO classification. Okay. So it's very easy. Also for regression, the follow-up for regression. If she is endometrial if the reason was endometrial hyperplasia, you will see her BMI. If it is less than 35, so more than 2 consecutive negative biopsies at 2 months interval. If more than 35 or is taking oral progesterone, so two or more consecutive negative endometrial biopsies at 6 months interval, then annual thereafter. So you will not discharge. If the BMI is low, you will discharge. If the BMI is high, you will review her annually. You will not discharge her. For abnormal atypical hyperplasia, 2 consecutive negative, 3 months in interval, then from 6 to 12 monthly review. Anytime you find there is a relapse, hysterectomy, total hysterectomy and bilateral salpingo-oophorectomy. It's easy. Just see what is going on. Anytime you find that the case is worsening, hysterectomy and bilateral salpingo-oophorectomy. The most important part here is that you will always forget the follow-up. So with reading once, twice, 3 times, you will remember it. Okay.
Okay, thank you.
Thank you. So
actually, I will add one point simply, just very nicely explained. We should remember that atypical hyperplasia is dangerous and it needs surgical treatment. But without atypia is benign and it needs medical treatment.
Yes.
Just big thing.
Okay.
I want to add this.
Missed you in these 2 days.
Sorry, I was actually traveling now.
Yeah, and I was not here as well. We didn't do sessions in about 2 days.
I was traveling from Pakistan to Saudi, so I was busy.
Yeah. Okay.
You're welcome.
Oh, thank you, dear. Thank you, dear.
13-year-old girl is present.
13. What? We did this. You are going for what? We did this. We did
next question. I think we go to
yeah.
3.
We did all questions. She is sleeping. She is asleep. You're still early. It's still 8 in your country.
Yes. Menstrual syndrome. Okay.
Yeah. BMS. One of the I hate it. Okay.
18-year-old girl presented to the gynecology clinic with severe mood swings and delay for a week before the onset of their period.
Okay, Dr. Iman, wait before we do it, because this will help us a lot.
الدياجرام بتاعها okay.
Because this one will really help us at least know what is going on. This one. Yeah.
Yes. Yes, this is totally, if you want to read the PMS, these two are sufficient.
Yeah. This will help you. First,
Yes,
this is the
whole
types.
guideline.
Yeah,
Yeah.
this is the types of BMS. Okay.
Yes. Yeah, yeah.
It tells you what to do in every situation.
Yes.
So
we have to, sometimes they give the graph, in question.
yeah, but
And,
this was before, but I think now it's difficult to them for to put graphs in the exam. I'm happy for this because really they would give you like cystoscopic pictures and they were giving all type of things. Okay, Dr. Ghazala, can you summarize this one for us?
Okay, I will try my best. Actually, this is the premenstrual syndrome. We should first keep it in mind that this is premenstrual syndrome is 1 week before female has 1 week before the periods, female has some symptoms which are
either
sometimes tolerable.
somatic. Yes, sometimes it is only somatic. Sometimes it is psychological. So it differs from one patient to another.
Yeah, exactly. So he is telling us in the first graph, if you see, he is telling symptoms cyclical and relieved by menstruations. Yani ke symptom patient has symptoms, but when the menses comes, she becomes symptom free and she becomes relaxed. So in the graph, he is telling this blue line, this is days of menstrual cycle, and this is red spot is for the menstruation. Yani ke patient has the symptoms relieved by menstruation. This is physiological type. This is yani ke no problem. You don't need any treatment, just counseling the patient, reassure, tell her this is the normal thing. You just yani ke try to cope with it. This is, don't need any treatment. Then the second graph, you see, this is long, this blue line, long graph.
So
he's telling here
more
symptoms cyclical. Yeah, yes, symptoms more. And these are relieved by menstruation because of this red, this sphere.
The graph goes down, so the curve goes down on menstruation.
Yeah, and he's telling that this graph, from this we should know this affects the quality of life. In the first graph, that is not affecting the quality of life because that was mild and physiological. It is affecting the quality of life. So what it is called core premenstrual disorder, premenstrual syndrome, or premenstrual dysphoric disorder.
Yeah.
So in this, we will consider all alternative approaches to treatment. Yani ke from the coagulative behavior therapy, and then for the this.
We will tell it after this. Don't worry.
Yes. Okay. Then the third graph we come now. You see here the graph is up and
never goes down.
The symptoms cyclical.
Yeah, but
not
never
down.
goes, not coming down. She is not even with. She will get some sense of being relieved, but she is not totally relieved.
Yes,
this
also affects the quality of life.
Yeah.
But it is written, it is written no symptom free week. So not totally relief.
Yeah, no totally relief.
Yes. So this is called as premenstrual exacerbation. Premenstrual exacerbation. So treatment should aim to treat underlying the medical, physical, or psychiatric condition or suppress the ovulation by anything OCPs or hormonal treatment.
danazole or anything.
Yeah, yeah. Okay, now, so up till now, we have read physiological, core premenstrual, and premenstrual exacerbation, 3 things. Now, 4th one is he's telling, you see, in this graph, only the blue graph coming down, but no menstruation. No red square are seen in this graph. So when we see this graph, we should see that symptoms are cyclical and there is symptom-free week because their graph is coming up and down and it is affecting the quality of life. But no menstruation in this. Okay, this is called as premenstrual disorder with absent menstruation.
She has no menstruation.
Yes. So treat as the core premenstrual disorder. Okay. Next, now this graph. Next graph is also blue graph coming up and totally coming down. But here with the red square, also there is green. Green rectangle. This is he's telling this in this graph symptoms are cyclical and these are relieved by menstruation because there is menstruation and there is symptom-free week also.
But
and
this
it
is
will
induced,
also affect the life.
But this one is induced by progesterone.
Yes, yes. This periods came because of progesterone treatment. So this is progesterone induced premenstrual disorder.
Yeah.
Okay. And alternative progesterone treatment. Then last is, very regular, just like in CTG, we see the sinusoidal pattern. Like this is also, when we see this graph, we say non-cyclical symptoms, no symptom-free week, and constant effect on the quality of life, but there is menstruation.
Yeah.
And here we should, here psychological disorder, not premenstrual disorder.
This one, she is crazy all the time. Others were crazy sometimes.
Yes, you are right. Then,
not crazy sometimes, but this one.
Yes, that's why we have to give the psychiatric referral.
Yeah.
So, so far now we should keep it in mind. First is the physiological premenstrual disorder. Second, core menstrual disorder. Third was premenstrual exacerbation. Fourth was premenstrual disorder with absent menstruation. And fifth was progesterone-induced premenstrual disorder. And last one is psychological, which is graph is up and there is menstruation down.
Okay.
So menstruation is only absent in premenstrual disorder with absent menstruation. Yeah.
Okay, thank you, dear. Thank you so much.
Welcome, dear.
Okay, I'll go for the treatment. This one is also,
yes, please.
Yeah, this one is very, very important. If you know it, you know everything. First, our first line is lifestyle modification, which exercise, vitamin B6, plus cognitive behavioral therapy. You will go for combined new generation pill. This is pills containing desogestrel, because you don't want to give her the regular progesterone. You need a specific progesterone, because one of the theories for PMS is that it is a progesterone hypersensitivity. So you don't want the regular progesterone. So combine new generation pills, which is known to us like Yasmin. This is the most common pill known to us. Or continuous or luteal low dose selective serotonin reuptake inhibitors. Okay.
Yes,
citalopram or escitalopram, 10 milligram.
Yeah.
Second
this 10
line,
milligram is important because in the next line treatment, the dose will increase.
Yeah, because
so we should remember.
This is low dose. The second line is estradiol patch. So estradiol patch is for estrogen. So you need to add micronized progesterone, and he's saying micronized progesterone because this is the least affecting the PMS, and you will give it in the least possible dose, which is ranging from 100 milligrams to 200 milligrams. You will give her not all throughout. No, you will give her from day 17 to day 28 orally or vaginally. And he is preferring vaginally because vaginally he's saying its side effects will be less. Plus, or you can substitute micronized progesterone with levonorgestrel IUS, which is Mirena. Or you can use the higher dose selective serotonin reuptake inhibitor continuously, or luteal as well. You will go do citalopram or escitalopram. Now it is 20 to 40 milligrams. First we will give 10. Now we will give 20 to 40. Third line is GnRH analog, but if you are going for GnRH analog, you have to add back hormone replacement therapy, either continuous combined estrogen plus progesterone.
Yes, excuse me. Why we are giving this add back therapy?
Because GnRH analogs, they affect the
bones. They affect the bones, osteoporosis. Yes.
Yeah, they are causing osteoporosis. So you have to add this, and they also cause menopausal-like symptoms.
Yes, yes.
So you have to give her a hormone replacement therapy. Okay.
Yes.
The last thing is surgical treatment. Surgical treatment here, you have to do bilateral salpingo-oophorectomy, because this is you can even go for salpingo-oophorectomy without doing hysterectomy.
Yes.
Yeah, the important part here is to remove the ovaries.
Source of hormones.
Yeah, plus or minus HRT according to whether she is retaining her uterus or no, and what will you get. So if you know these two charts, you know everything about BMS.
So yes, thank you. You revised our BMS.
Yeah, I'm trying to revise the most important points so we know.
Yes,
okay.
Thank you.
So first question, Dr. Iman.
18-year-old girl present to the gynecology clinic with severe mood swings, delay for a week before the onset of her period. She also feels drained due to heavy bleeding during her periods. This affects her relationship with her boyfriend, and with whom she is in a stable cohabiting relationship. It also affects her university performance as a new student. Affect her life.
So she is, yeah. So this is what type? Which type?
Second one.
Yeah.
Dysphoric, affecting the quality of life.
Affecting the quality of life.
But clinical, but it is cyclical.
Yeah, and it's a cyclical. So what is the first line treatment?
She will have SSRI, but in the she can go for OC pills also.
Yeah, but with which?
But the newer OC pills.
I said which one? So
drospirenone. With cyproterone.
Drospirenone, yeah, the one with
drospirenone. Yes.
Okay. This patient, she is already having a boyfriend, so she needs plus
contraception.
Yeah, she needs a contraception. So we can use the COC as like for both actions, to control her mood swings plus doing plus contraception. So let's see the answer. Yeah, sorry. Yeah, the answer is E. Premenstrual syndrome in adolescents with a need for contraception and the treatment of menorrhagia as well. We forgot that she has menorrhagia. May benefit from a combined oral.
And she's still a teenager, and drospirenone is also a treatment of choice for acne and all that skin.
Yeah.
Drospirenone is third generation or fourth generation?
Drospirenone, I think it's
drospirenone.
Third. I think third generation.
Yes. No, the crypto is the other one is the one for
Cyproteron acetate is anti this thing now.
yeah, this one cyproteron. This one is the one for acne, I think.
Yes, like
No,
in the
both,
dinazole.
but drosperinone is for mild forms and cyproteron is for the
For the severe form.
severe form.
Acne,
Yeah.
yes.
So she's 18, no? She's a teenager. She's in a stable relation. So she needs OC pills and drosperinone will be better for her, mild.
Okay, let's go for the next one.
24-year-old woman present to the gynecology clinic with painful periods. She takes a fiber supplement for managing constipation. She also mentions that her GP specialty asked her to discuss her repeated need to specifically asked her to discuss her repeated need to see the GP about low mood lasting a week or fortnight that gets better after she has the period pain. The GP had advised her to see a counselor, but she is not keen to discuss this with anyone else. Low mood
Okay.
lasting.
Okay, this is 24 years old. She is taking fiber for managing constipation, and she has low moods, and she refused the cognitive behavioral therapy, which this is what her GP advised, to go see a specialist or a counselor, but she refused. So what can you give this patient?
Can we do CBT for her? CBT, cognitive behavior therapy.
She refused to speak to a counselor. She already refused, declined this. She declines cognitive behavioral therapy. She refused to talk to a counselor.
Maybe selective serotonin reuptake.
Yeah, I think she most probably needs a selective serotonin reuptake inhibitor, because COC is sometimes it causes constipation, and she already is suffering from it.
Okay.
So for me, I will go for selective serotonin reuptake inhibitor, because for this patient, I don't want to exacerbate her GIT problems. She already is having GIT problems, and COC have GIT side effects. So I don't want to exacerbate this.
In the first line, they also mentioned vitamin B6, no? So which is what, pyridoxine?
Yeah, where no, she look, this stuff are only if she is not, if the problem is not affecting her quality of life. This is affecting
first line treatment.
life. Yeah, this is affecting her quality of life to a degree that she is coming to you, to the she is coming to the GP very frequently. So this is very, very, very big issue for her, and it is not lasting one week; it's lasting 2 weeks. So this is a severe form. For me, I will go for selective serotonin reuptake inhibitor. Okay, I'll send a new link. Okay, because now we are less than 1 minute. I will send